We're talking health leads. Please make some noise for Tigee Hill and Alexandra Quinn.
Good morning. You do better than that. Good morning. Good morning. I'm Alexandra Quinn. I'm the CEO of Health Leads. We'll tell you a little about that later.
And I'm Tigee Hill. I'm the Director of Partnerships and Initiatives, and we'll talk more about that too.
I'm really excited to be here. I spent the past 18 years in the nonprofit sector, and half of that was with young people, and I don't get to do that as much now. I fully believe, because I was trusted to do a lot of things in my family and in work really young, that it is going to be you all that actually gets our country out of the health mess we're going to explain to you today. I had lunch or breakfast with a good friend of mine who's from here, and he was trying to teach me to say Louisville right, so he said Louisville. Is that right? Louisville. Better? Better. Okay. So you guys can correct me along the way. He was like, please don't embarrass me. Like, you're a Yankee. I actually live in California now, but he still sees me as a Yankee. Don't come to my community and embarrass me, so you can tell me how I do with that too. I'm the daughter of a social worker from rural Texas and a small-time entrepreneur from New York. And so the work that we do really marries the two for me. And what we're going to do today is do a little bit on health, a little like public health class. How many of you are thinking about a health profession, maybe? It's a lot of you. What are you thinking? So someone, what are you thinking? Pediatrician. What else? Who else raised their hand? Surgery, anesthesiology. Wow. Who else? Yeah. Paramedic. Nice. Yeah. Medical examiner. Wow. Back there. Physical therapist. Love it. Yeah. Neurologist. Very cool. Yeah. ER nurse. That's all. Well, we need more ER nurses. That's for sure. Yeah. Neuroscience. Very cool. Yeah. Neurosurgeon. Way back there. Wow, a lot of surgery. That's pretty impressive. Yeah. Oncologist. Very cool. Say it again. Psychologist. Very cool. Anyone else want to share? Yeah. Medical marijuana. Very cool. That's big in California, I'll tell you that. Anyone else? Health profession? Pediatric nurse. How many of you have either cared for someone in your family or had a family member that needed to be cared for? It's a lot of people, right? And how many of you think health is going to the doctor? Partially, right? Good. So we have all of you probably have a big understanding of health, or more understanding of health than a lot of folks we talk to. So if you can go to, do we have the clicker?
Clicker.
Hopefully let's see. Okay, so I'm going to tell some sad stories using facts and data, and then we're going to tell a happy story, and then we're going to ask you to try to make the happy stories everywhere. Sound good? All right. So one of the ways we measure health in the United States is life expectancy. And the first sad piece of data I'm going to tell you about is how are we doing as a country? So as a country in the United States, life expectancy is declining for the entire country. And so that's what you can see on the chart here, the years and then other countries. And in other countries, life expectancy is actually going up. And one of the wild parts is in the United States, we actually spend more money on health. So our life expectancy is declining, yet we're spending more money on health. Does that seem like a good deal? No, it seems like a really bad deal. All right, so let's talk about what do we mean by health. So often we think about length and quality of life. What are other factors that play into health? Anyone? Say again? Food, yes, big one. Mental health? Access to health, yep. What else? Yeah, exercise for sure. Emotional health, yes. Environment? Same thing, environment? That's right. Yes. Income, huge impact on health. All right, so let's talk through this. So what percentage is the environment? 10% of our health is about environment. Education, employment, income, family care and support, and community safety, 40%. Access to care and quality of care, it's not that much, right? Surprising. And then tobacco use, mental health, again, smaller than most people anticipate, except this audience. So when we think about health, we think about 80% of health inputs are modifiable. So let's talk about that. What do you think, does anybody know what the number one predictor of your health is? Shout it out. Genetics? Other? Lifestyle? Where you're born. So it's actually zip code. So the number one predictor of your health is zip code. That's true across the country. That's true here in, okay, I'm going to try it. Louisville? Louisville. Okay, it's okay. I'll get better as I go along. And what is tragic about this is there's a 10-year difference between different parts of our metro area here. And by the way, if you start adding race as another input, it's even more stark. So this is a sad story, right? Here's the deal. It's not only here. This is the entirety of our country. So what this looks at, the orange, is where people are doing less well. And that's based on health and income. The greenish is where you're doing a little bit better. But if you were to double click on these, and you can, this is actually a study that came out, even in places that look green, there are parts that are orange. So as a country, we are not healthy. Again, sad stories. So what do we do? And at Health Leads, we believe you can do something, because 80% of these factors are shaped by life outside the clinic. And at Health Leads, we believe in people, empowering people, and changing systems. And so Tigee's going to talk a little bit about Health Leads.
Great, thank you. Is it this one?
Yeah.
Great. Good afternoon, everyone. And a little bit about me. So like Alex, I have worked with youth for most of my career and strongly believe in what you all can do. I've witnessed it firsthand. Has anyone ever heard of school-based health centers? Do you all have those here? Clinics in your high school? All right, great. So I used to work with school-based health centers, and I was an Aspen Institute scholar a couple of years ago, and there was a session.
It's a big deal, by the way.
Thank you. And I'm so excited for you all to have the opportunity to go there. My favorite session when I was there was hearing the presentations from the winners. So one of the groups there was one of the high schools I worked with in Chicago, Wendell Phillips. So when I saw their name, I was like, I'm going to this session, and all of the teams did an awesome job. So again, super excited that you all have this opportunity. So a little bit about Health Leads. Health Leads is a national nonprofit. We're based in Boston, but we do work all over the country. We work with health systems. We've worked with individuals, community residents for over 20 years to address the non-medical factors that influence their health. So those are things like housing, like you all mentioned, food, having heat, having clean water, transportation, childcare, so they can pursue education or even work. And the way we did this was working with college students, and in some of our areas like California, working with high school students. So the high school students and the college students would ask questions of the patients at their medical appointments. Do you have enough food at home? Do you have adequate housing? And then they will find resources for those families and then follow up with them to make sure they actually connected with the resources. And we had a lot of students every year who would eagerly apply for the program. It was very competitive, and they were excited to work with the families and connect them with these resources. But what they found was it wasn't as simple as they thought. Many thought they would come in, they would have this list of resources, they'll give it to the families, and it'll be all good. But what they found instead was the families ran into a lot of obstacles. They ran into programs with hours that made it impossible for the families to get there and get the resources. So I'm talking like they're open from 12 to 2, and then they close and they're open from 3 to 4. But if you're working, it's difficult for you to leave work, travel all the way to the other side of town so you can get these resources. So they existed, but they weren't accessible for many of our families. Another thing we saw was the communities that were in most need for the resources. So like the map you all saw earlier, where to the left, there weren't as many trees and more asthma. So the communities where there was more need, the resources didn't exist. The resources were actually on the resource-rich side of the states or the cities. Other things that we saw were systems just didn't make sense. There was a lot of paperwork. Families would be asked to come back and forth. Some who qualified didn't get the resources they were supposed to get. It was just crazy, just obstacle after obstacle. And this piece here where you all see racism. So there were communities where there is history there, where folks were denied adequate housing, where the housing is drafty or old, and that drives up their utility bills, and then they can't afford their utility bills, and it's just a spiral. So this was very frustrating, not only for the patients and the families, but also for the students who were working with them. But one thing that they were really impressed by was how resilient these communities were. All of these obstacles that they encountered, many of them found incredible workarounds and ways to survive and get what they needed for their families. Many of them were brilliant and knew the resources better than we did. They helped inform what are the better resources, where do we need more resources, and really helped us to extend our services to other folks who needed them. Love, there's a lot of love in those communities, which is really important. And I heard some of you all speak about that earlier, about your mom in the back, your best friend's mom, folks at Temple. So these people in the community who are supportive, huge asset. We would have to close the cases, basically saying, did the patient get the resource or not? And one of the ways we could close the case was the need was met elsewhere. And that happened often where families, maybe they didn't have a place to live, but then they were able to stay with a family member, or their best friend helped out with childcare. So the assets in the community was huge for addressing the barriers our families experienced. So at Health Leads, we're all about removing those barriers. We learned over time, yes, it's important to connect families with resources, with housing, with utilities, with transportation, but it's not enough. We need to get to the root of the issue, the reason that these communities didn't have those resources to begin with. So we work with health systems and other stakeholders as a bridge to community members to help remove those barriers so that we can have health, well-being, and dignity for every person in every community. So health equity, what is health equity? So I actually got this definition from the Louisville Metro Health Equity Report. Would someone read this definition, please? Any volunteers?
So many.
Yes, you all the way in the back. Thank you.
I'm Joseph Falcon from the Academy at Shawnee.
Okay.
Health equity, what is this? In Louisville, health equity means that everyone has a fair and just opportunity to be healthy and reach their full human potential. A person's identities, whatever they may be, should not predict how long or how well one will live.
Great. Thank you. Thank you. And may I have a volunteer? What stands out to you when you read that definition? Right here in the back, please. Please. Anyone? Is there someone up? Okay.
Oh, is it not there?
Did it go out?
Oh, there you go. Okay.
Okay, all right. Well, I will. So a few things that stand out to me here is everyone has a fair and just opportunity. So I mentioned earlier how some areas there's old housing, there are old grocery stores, there are no grocery stores, there isn't access, there isn't opportunity. But that there should be opportunity regardless of a person's identity. So regardless of your zip code, regardless of your race, regardless of your age, regardless of your gender. Can you all sort of see that? Okay. So here we want to talk about the difference between equality and equity. So imagine we're developing a wellness program and we want everyone to exercise more, and we're going to do that by giving folks a bike so that they can use biking as a form of exercise. And so equality here, the first piece at the top of the slide, everyone got the same exact bike, regardless of their height, regardless of their ability, regardless of their, the smaller child here. So in the first picture, this bike really only works for one person, and that's for the woman there. Here you see the first woman is in a wheelchair, so she can't use that bike. And then the second picture, you see the gentleman is really tall and scrunched up trying to ride the bike. And then we have the young child here on the end where the bike is too big. So what we're striving for is the second picture here, which is equity, where we're giving people what they need. We're looking at where they are and what they need to get to a point where they can lead a healthy life. And now Alex is going to talk about health inequities.
Can someone read this definition? Should do it again. You were good the first time.
Health inequities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by social disadvantaged populations.
So I'm going to give you some more sad data about our country and here. And part of this has to do with, at Health Leads, again, we believe in how do you see the individual and support the individual, but change the system. And you can't actually change the system without looking at and addressing health inequities. And so what's that mean? When we think about inputs to inequity, a big one, and thinking about life expectancy, and then we look at who has attainment to education as an input. So college graduates can expect to live 5 years longer than non-college graduates. And that's not only about going to college, it's about the environment that was created that makes you want to attain other education, whether it be college, other higher ed, technical learning. And that means that we are seeing life expectancy be impacted by those modifiable factors we talked about before. Then when you start to look at things like race, so what this looks at is infant mortality. And infant mortality is an important health metric. And what this slide tells you is that it doesn't, let's think about education, but what if you overlay education with race? Middle-class black women, babies are less likely to live to their first year as lower educated white women. And these stats around infant mortality are that of third world countries. And this is true across the United States. When we look at Louisville, I'm getting close there. And we think about low birth weight. So why is low birth weight important? You may know this is a health-educated group, but low birth weight is thought about as a starting gate measure. So that if you are born with low birth weight, they can predict things like your educational attainment may not be as great. You may have more sickness throughout your life. The national average for low birth weight is, depending on the study, between 5 and 8%. For black families in Louisville, it's 14%. Low-income families across the United States, it's around 8%. And while 14% may seem low, that's incredibly high. But if you look at low birth weight across the spectrum of race, none of them are good. So that means we have a lot to solve nationally and locally. But here's the deal. Each one of you raise your hands around caretaking, right? Each one of you, I would argue, is actually a health catalyst, whether it be those who are going to be going into the professional health field or those of you that can just impact the other 80% of the modifiable factors. And what we want to talk a little bit about now is the assets that each one of you has access to literally change these numbers and change the trajectory locally and nationally.
Okay. Thank you. So another thing we want you to consider is community assets. And here we define community assets as untapped potential, which can be put into action to improve conditions. And there may be some that are being tapped a little bit, but they can be tapped a little more. And those assets can be people. So it could be celebrities. We put Jennifer Lawrence here because she's from here. So you can reach out to her like, hey, Jennifer, we're from the same town. We need your help. Layla Ali, who isn't from here but is connected and passionate about this area. Nurses, we heard about moms earlier. First responders, grandparents, neighbors, teachers, coaches. And then here, the picture at the bottom left, right for you all, is a picture of winners of this challenge in Aspen. So for you all to visualize the win and you being in Aspen, but youth, you all are a huge asset. And then buildings and space. Your school can be an asset, churches, parks. This vacant lot here, you could build a building there. You could make a soccer field, banks. So our challenge for you is to develop a solution to reduce a health inequity facing your community, using your community's assets, and identifying where more support is needed. Thank you, and we have a few minutes for questions. Yay.
Mike, you want people with a mic, right? Yeah.
Hi, I'm Zach from J-Town High School. So you said that, when you were talking about equity versus equality, when is equality better than equity, or is there ever a time where they can both be used together?
It's a good question. I mean, I'd argue it's equity over equality. I don't know, what would you say?
That would be my argument too. I would start with equity, and then if you find that everyone in the room needs the same thing, then equality.
Yeah.
But I would, do the research first to find out what people need.
I think it's hard. Right now, there's so much language around equity, race equity, equality, and so the language similar to what you saw before is so important in this, and I love the question because of that too. Yeah. Pass the mic.
All right, I'm Elijah from Eastern High School, and what I just wanted to ask is something like infant mortality rate is seemingly so far detached from something that we could do. Honestly, I mean, it seems like a very more scientific and distant thing. So maybe how can we work on actually, how can we have an impact on that?
So I'd go back. Oh, can I go back? Is that even possible? I think this only goes forward. If you think about that slide with the 80% are modifiable factors, so inputs in infant mortality are food, showing up for the doctor on time, housing. So when we think about the parts of the challenge, it's about how do you think about food in your community? How do you think about housing, not only homelessness, but subpar housing? How do you think about utility shutoff protection? And so those are all the more important factors to infant mortality, even than the medical care itself. And so that's the way I'd frame it. It's a good question.
And I would add, there's a health system in Cincinnati that works with their local communities to address preterm births. And it started with education, so moms need to get to their doctor's appointments. Basically what moms need and what they need to do to support those moms. And the community came together to make sure that the moms were getting the support they needed. So you could think of it that way too.
Yeah. Here. Last question. We have to wait for the mic.
Hi, my name is Shreya. I go to DuPont Mino High School. And I was wondering how you answer to people that believe being healthy means being skinny.
Oh, it's interesting. Don't get that question a lot. I mean, I think it's dependent on what you need for yourself, right? So that's nothing we'd ever promote. But health is so individual, body weight is so individual, and that's about a conversation with your doctor.
And I think one thing that I've used is showing how too skinny can be unhealthy. So, kind of starting there and then working back to what healthy is and the different faces of healthy.
That's right.
I'm Lee Henry from the Brown School, and my question is what do you think is the biggest systemic barrier to proper health in Louisville and cities like it? Like the number one that kind of, in a way, trumps the others and is the biggest problem right now.
You want to answer that?
The biggest systemic barrier in Louisville specifically?
And elsewhere too, right?
And elsewhere?
Yeah.
I'm going to have to go with systemic racism.
Yeah, I would agree.
It just runs so deeply. We're talking centuries, and we're seeing the consequences of it years later. We see it in housing. We see it in employment opportunities. We see it in health outcomes. We see it in education. Like, it permeates every aspect of those communities. So yeah, I'm going to have to go with systemic racism.
There's a great extra credit book, if you want, called The Color of Law, that explains housing in the United States and systemic inequity and racism within housing, which explains a lot, something called redlining, which explains a lot of our health too. All right, I think you're next, and then we'll go over here. Do we have any over here? Oh, so many.
Yeah.
Hi, my name is Malaysia from Shawnee. I was wondering, with Donald Trump trying to get rid of food stamps, healthcare, and any possible way for the downtown people to get easy access, how do you think it's going to affect everybody once he gets rid of it?
It's a great question. So what we've seen is an opposite to what's happening nationally in our work. Hyper-local interventions are actually able to address food insecurity and others more so than national policy. So there's a lot of rhetoric on the national policy stage, and there are some things that impact local, but what a community can do locally, and depending on what your state actually mandates or not, you can create interventions, you can break systemic inequity in a community. And it's not like it doesn't matter what he's doing, it does, but there's so much more power and there's so much more dollars actually that flow in a state and a local community. It's just the national rhetoric overshadows a lot of that.
Should we
Over
go
here.
over here? Right here, please.
There, and then we'll come back over here.
Yep.
So my name is Manaya Hillman. I'm from Louisville High School.
Okay.
And I have a question about when you all were talking about how life expectancy is declining versus increasing in other countries. So my question is, do you think our life expectancy is declining because we use a lot more chemicals versus other countries that use natural remedies?
So, do you want to...
Sure, go for it.
it could be. It's not any of the stuff that that personally at Health Leads we've focused on. I think what we focused on is, again, the 80% of modifiable factors that impact life expectancy, and that's where some of the longer studies go to, but I'm not familiar with studies around how we're using chemicals, but happy to send you more information. And I think you would be.
I don't think it's just one factor either. I think that could be one of the many factors that's contributing to it.
Yes. Do you want to here and then there, and then we'll come back here? Sound good? We have a minute, but we're happy to answer questions after, too. And we really want you to do this challenge, and we're happy to help you with that, too.
Yeah. Hi, I'm Sydney from Eastern High School, and I was just wondering, since you did show those other countries that did have significantly increasing life expectancy, are there common themes between them that kind of help lift up that life expectancy there?
Yes, and so there's a slide we didn't show, which is a similar graph on spending on social needs, so spending on housing and food and utilities. All those countries spend a lot more on health insurance, housing, food systems, and that's where, we're actually at the bottom of social spending. So that's one of the big ones. And again, we're happy to share more data too, especially if you take this as a challenge, or even if you don't.
Yeah.
All right, probably one more question. I want to do over there. Okay, we're getting pointed to you back there. Who has chicken at your house? Is that right? That's you. Okay. I do want to come. Are you kidding? My mom makes a good fried chicken, so I don't know. It's my mom versus your. Okay, cool.
My name is Josue Velasquez. I go to Marion Seymour. What roles do insurance companies play in health inequity and equity?
Such a good question. So that's about an hour and a half lecture and back and forth. So it depends on the health insurance. It depends on what they're incentivized by. We work with some groups that are actually integrated healthcare systems where they provide the service and they provide the healthcare. They're incentivized to keep people healthier. There are some healthcare insurers that are incentivized by other things, and it really depends on place. But again, happy to talk a lot more about that too, and especially if you want to think about that as part of a challenge.
And I would just say, look up North Carolina. North Carolina is a state that's focusing on this, and they're doing it through their Medicaid program, where they're screening for social needs and addressing it through Medicaid, so through insurance.
And thank you. Happy to help in any way. So appreciated all the good questions and excited for
Thanks,
this.
everyone.
Excuse me?
Y'all give it up for Tigee and Alexandra. Wow. Young people, are you hungry? Yeah, y'all not. There's a difference between